Namaste everyone. Today I'm going to talk about a very basic topic of primary replacement of the humeral head in case of proximal humerus fracture. So if you look at proximal humerus fracture from orthopedic point of view, you'll see head, shaft and the tubercles. So basically as an orthopedic surgeon, we think about the bone pieces and how to assemble these bone pieces. This approach is little different from when we look from a shoulder surgeon perspective. From shoulder surgeon perspective, we look at supra, infra and subscapularis. So what we are looking at the soft tissue status. So this is the basic difference. As an orthopedic surgeon's general orthopedist, we look at the bone fragments, whereas as a shoulder surgeon, we look at the soft tissue attachment at this bone fragment and thinking of how to fix and how to restore this soft tissue attachment. This was a very interesting case. A 59-year-old gentleman sustained a road traffic accident 2 days ago, presented to us with severely displaced and the comminuted proximal humerus fracture. We fixed them with the Philos plate, and the intraoperatively the fixation looks pretty okay. But in subsequent follow-up, the patient came to us after 6 weeks of follow-up. In 6 weeks' time, you can see that there is a healing of the humeral head with the shaft, but you can see there the GT attachment has displaced. If you look into this, the lateral view, scapular Y view, you can see that the GT and the LT both are displaced, they have not healed. Although the fracture united, the GT and the LT did not unite, and this patient had a drop arm test, a very poor function of the shoulder. So my first take home message is fracture union alone is not sufficient. The restoration of soft tissue attachment is critical for shoulder function. GT and LT secure fixation is very, very important for shoulder function because the rotator cuff is attached here, and for movement of the shoulder, the function and the attachment of the rotator cuff is very, very vital. There are several treatment principles of proximal humerus fracture. As far as one of the common principle concern, so you first have to think about if you can achieve GT and LT union with the shaft or not. If you can achieve GT and LT union, then you have lots of options to offer for this patient, like conservative, pinning itself can work, various osteosynthesis modality will work, hemi replacement will work, total replacement will work. But if you cannot achieve a GT and LT union with the shaft, then the only option you have is the rotator or the reverse shoulder arthroplasty, because in reverse shoulder arthroplasty, the functions of rotator cuff are partially replaced by the tensioning of the deltoid fibers. That is why in those cases, only reverse shoulder arthroplasty will work. The second principle is if the humeral head is salvageable, then you can do osteosynthesis. If humeral head is not salvageable, the only option left to you is the replacement arthroplasty. For example, a very osteoporotic humeral head, if there is a humeral head split, if the humeral head is not reducible in case of fracture dislocation, in these cases, the only option left is the replacement arthroplasty. So the second take-home message is the GT and LT and the humeral head. These are the three important structures, and the status of these structure will determine the treatment option for proximal humerus fracture. So whenever you see a proximal humerus fracture, think on this line. Can I fix GT? Can I fix LT? And can I fix humeral head or not? And this will determine what type of surgery you are going to do to this patient. So this was a second case, example, 55-year-old farmer from Dolakha district sustained a fall injury in a hill. When he presented to us, he was just 55-year-old. His glenoid status was normal. we thought that we can fix his, GT and LT, but his, humeral head was not fixable. So intraoperatively, we decided to do a hemiarthroplasty. This was one of my old case. The hemiarthroplasty was done. We pulled the GT down to fix into the shaft, and then you can see that the GT has healed. And this is the patient. This is not in the front. In the back side, this is the patient, which you can see is doing his daily household chores at 3 years, a follow-up of patient. This is another case, again a young guy, 58-year-old office worker from Sarlahi district, sustained a fall injury in front of his office and sustained this comminuted fracture of the humeral head. When we started operating, initial plan was again osteosynthesis for this patient, but when we went inside, we found that the humeral head is just a shell of bones, like an eggshell. So we intraoperatively decided to do a hemi replacement for this patient. This was immediate post-op. Finally, the GT healed to its shaft, and then you can see at 1 year follow-up, he has a reasonable, range of motion and well pain control. So, as far as the arthroplasty algorithm is concerned, this is divided into either the patient is young or the patient is old. If the patient is younger than 60 years, then you classify them according to needs and divide them. Either it is a one part or two part fracture. If it is one part or two part fracture, the treatment can be, if it is undisplaced, non-operative. If it is displaced, osteosynthesis is the better option. If it is 3 or 4 part fracture, it can again be divided into 3 groups. If you can fix the humeral head and the tubercle, osteosynthesis is still a good option in this particular case. But if you cannot fix the humeral head because it is very much osteoporotic, or there is only thin shell, or there is a head split fracture, but you can fix the tubercle, in those cases you can do a hemi-shoulder arthroplasty or total shoulder arthroplasty based upon the status of the glenoid. If the humeral head cannot be fixed and the tubercle can also not be fixed, then probably the only option left with us is the reverse shoulder arthroplasty. And this is the algorithm I use for patient less than 60-year-old. When the patient is more than 60-year-old, again divide them into 1-2 part and the 3-4 part. If it is 1 and 2 part, usually non-operative treatment or osteosynthesis will work. If it is 3 and 4 part fracture, again divide them into 3 groups. If the humeral head can be fixed and the tubercle can be fixed, osteosynthesis still is an option in this group of patient. Even in the older group of patient, if humeral head cannot be fixed, tubercle can be fixed, probably total shoulder arthroplasty or reverse shoulder arthroplasty is an option. And if humeral head cannot be fixed and the tubercle cannot be fixed, the reverse shoulder arthroplasty is the only option for this patient. So the take-home message number 3 is, if the head is not fixable, replacement is the only option. Either you do a hemi, total, or reverse shoulder arthroplasty. If the tubercle is not fixable, then reverse shoulder arthroplasty is the only option. So these are the option for, a replacement option for proximal humerus fracture. This is one of the paper by one of my friend, Dr. Shashank, in a review article where he says that proximal humeral fracture treatment depends upon either the patient is young and it is elderly and osteoporotic. When it is young, most likely these are conservative and open reduction internal fixation. When these patients are little elderly, conservative, and the replacement comes into the picture. So they say that in elderly patient, shoulder replacement is an option of treatment in comminuted and severely displaced fractures. This is another paper in 2019, which is published in 2019, which shows that there is an increasing role of reverse shoulder arthroplasty in the treatment of proximal humerus fracture. And they say that reverse shoulder arthroplasty is a choice of treatment in proximal humerus fracture, especially if it is an elderly and the displaced, whereas use of hemi-shoulder arthroplasty is fading and especially limited to very young age. Coming to the literatures, what they have to say in 2025 very quickly. This is paper from 2024, analyzing conservative or reverse outcome of conservative treatment versus reverse shoulder arthroplasty in displaced 3 and 4 part proximal humerus fracture in patient over 60. And they say that their results support the use of reverse shoulder arthroplasty in 3 and 4 part proximal humerus fracture. They say that RSA can significantly benefit in terms of improved prompts and patient satisfaction with low complication rates. Another paper studying long-term outcome of reverse shoulder arthroplasty versus non-operative treatment of 3 to 4 part proximal humerus fractures in elderly patient, results from a prior randomized controlled trial. They say that long-term treatment with reverse shoulder arthroplasty for displaced 3 or 4 part proximal humerus fractures provide better functional outcome compared to a non-operative treatment. Another paper which is published in October 2024, it says that it analyzes does the primary treatment of proximal humerus fracture shows favorable functional outcome over secondary treatment with reverse shoulder arthroplasty. So they have compared either primary shoulder arthroplasty or secondary shoulder arthroplasty. That means after some intervention has been done and the secondary treatment modality was the reverse shoulder arthroplasty. In this research, they say that range of motion in patient with complex displaced proximal humerus fractures after primary reverse shoulder arthroplasty is better than after secondary treatment. Therefore, they recommend reverse shoulder arthroplasty could be considered as a primary treatment, especially when optimal range of motion is of great importance to the patient. This is another paper from 2024, very recent in November, the effect of tuberosity healing on functional outcome after reverse shoulder arthroplasty. And they found that healing of the GT after reverse shoulder arthroplasty for proximal humerus fracture yield improved post-operative range of motion and strength, whereas patient-reported pain and function were largely not affected by GT healing, indicating merit of reverse shoulder arthroplasty for proximal humerus fracture regardless of the likelihood of the GT healing. This is a clinical survey among 340 patients, and this says that for 3 and 4 part fractures, if the patient is less than 60 years, osteosynthesis is the basic choice. Only very few will choose shoulder arthroplasty, and if the patient is more than 60 years, very few will choose osteosynthesis. Majority will choose reverse shoulder arthroplasty in the patients. So fourth take-home message is reverse shoulder arthroplasty has taken over hemiarthroplasty, total and osteosynthesis in recent past, especially for elderly and osteoporotic patient. Irrespective of GT healing, results are good after reverse shoulder arthroplasty. This is my final case. A 68-year-old lady fell from standing height 4 months ago, and this was the fracture, which looks pretty okay, minimally displaced. Some of our colleagues have decided to fix this and underwent a Philos plating. When they went inside, the head was not very much constructive to reconstruction. They put some bone graft substitute and tried to fix this with the Philos plate. After the fixation, after 3 to 4 weeks, the patient started having this reaction, the redness around the whole of the forearm, and the patient was consulted and investigated for infection. The infection was not found, but in subsequent follow-up, you could see that the proximal head was completely resolved and the screws were just, poking without any bone. We thought that this could be an infection, and we decided to, remove the plate and do a debridement, thorough debridement. But when we went inside, we found that this was not an infection, but this is allergic reaction to the bone graft substitute. So removed all the bone graft substitute and followed this patient up. So after removal of the bone graft substitute and the debridement, after in 2 weeks time, the redness has disappeared. The patient has completely improved, and then this patient was planned for reverse shoulder arthroplasty very soon. So to conclude my presentation, arthroplasty has become a trend in the treatment of proximal humerus fracture, especially in elderly and the displaced fractures. Reverse shoulder arthroplasty has gradually replaced hemi and even total shoulder arthroplasty because the GT and LT fixation or its union is unpredictable. Reverse shoulder arthroplasty works well even if GT fails to unite, and if you get a 3-part and 4-part fracture in the elderly, especially if it is displaced, think of reverse shoulder arthroplasty. Thank you very much.